62-year-old man is admitted with COPD and mild LV dysfunction, as well as symptomatic and recurrent atrial fibrillation despite antiarrhythmic drug therapy and DC cardioversion. After rate control with beta blockers, the patient's heart rate improves and he feels better. Given his AF despite optimal medical therapy, the patient is referred for radiofrequency ablation of AF. Commonly, what we do is a pulmonary venous isolation procedure. How it is done? We're going to go into the right atrium by venous access through the SVC. And from the right atrium, we're going to do a transseptal puncture, enter the left atrium. And usually the AF circuits will be located around the pulmonary veins in the left atrium. And we're going to do radiofrequency ablation in that area to ablate the AF circuits. It's a very effective procedure. Success rate is more than 70% to revert atrial fibrillation back to sinus rhythm. And the procedure is performed on anticoagulation with an INR of more than 2 and is deemed a success with a no inducible AF at the end of the case. But as expected, a small atrial septal defect was noted. That is because of the transseptal puncture that is associated with this procedure, with no other remarkable findings. That evening, in the ICU, patient is known to be hypotensive, tachycardic with increasing dyspnea. There is a concern for cardiac tamponade. It is possible because the patient was already on anticoagulation after a cardiac procedure, especially if the patient was on anticoagulation, there is a risk of development of tamponade. However, the arterial line did not show significant respiratory variation of the BP, which means they're saying there is no pulsus paradoxus. Echo showed a large circumferential effusion and the patient is referred for urgent pericardiocentesis. Why didn't the patient develop pulses on the arterial line despite a large hemodynamically significant pericardial effusion? The answer is very simple. That is because of AST that is induced by this procedure. Remember, the reason for development of pulsus paradoxus is exaggerated ventricular interdependence, which typically happens in patients with tamponade. So what do you mean by exaggerated ventricular interdependence? The right ventricle gets preferentially filled during inspiration by pushing the interventricular septum towards the left side, and left ventricle gets preferentially filled during expiration by pushing the interventricular septum towards the right side, compromising the right ventricular cavity and reducing the right ventricular inflows. And that's the reason why you develop pulsus paradoxus. In the presence of ASD, this exaggerated ventricular interdependence will be mitigated because the pressure can be shunted across left atrium and right atrium during inspiration and expiration. So there won't be pulsus paradoxus. So the right answer for this question is option number A. Remember, COPD is something that can produce pulsus paradoxus, as we know. So that's not the right answer here. So the right answer is going to be option number A.
Subscribe and press the bell icon so you never miss an update from PrepLadder.